Hi, everybody. Thank you for coming and joining us today. I am with a very special guest, Dr. Lars Blønd, who is a knee surgeon from Copenhagen in Denmark. And he's a global authority on patellar instability and patellar things in general, but particularly patellar instability. And he's developed some sort of state-of-the-art procedures for dealing with chronic patellar problems relating to a certain medical condition. Before we start, I just want to ask you, if you have questions, can you keep them until the end? It's only going to be a short webinar, and then we can answer them all at once. That will be helpful to me in taking the recording of this into a slideshow. So I'll just remind you of the parts of the knee that we're talking about. The mechanism that straightens your leg, which we call the extensor mechanism because it's extending your leg, consists of the patella, or the kneecap, and its communication structurally with the very strong quadriceps muscle of the thigh and connected to it by the quadriceps tendon. And then below the patella is the patellar tendon, so it's all one big mechanism really, with the patella sitting inside the quadriceps tendon, and it attaches down here onto the tibia at a point called the tibial tuberosity or the tibial tubercle. So from tibia, tibial tubercle, patellar tendon, patella, quads tendon, quads, the whole thing is one integrated structure going right up to actually as far as the hip. So that's what we're going to be talking about. I think those not too taxing. So now I'm going to introduce you to Lars. He has, of course, a Danish surname, which always struggles off my tongue because of that O with the line through. Blønd, Lars Blønd. But I know I don't say it quite right because I'm not Danish and my tongue doesn't do the right thing. Hi, Lars. Would you like to just introduce yourself and just tell us all what it is that you do on a daily basis and how you came to be interested in this topic?
Oh, thank you, Sheila, for the introduction. I'm very honored to be here. Yes, I'm an orthopedic surgeon and working part-time public and part-time in a private practice. And I do a lot of knees, a lot of shoulders, and I guess that in Denmark I'm recognized as being a good shoulder surgeon, but internationally I'm known as a patellar instability surgeon. So, and that's my main interest, that's patient with patellar instability, and I see a lot of these patients.
So what started you off in that particular interest? Do you recall?
Yeah, it was just coming out as a doctor. I wanted to become an orthopedic surgeon, and I saw a lot of these young patients having treatment that I thought that they don't know what they're doing, and these patients were operated on again and again, and there was a lot of discussion on how to treat these patients with patellar problems. And I thought that they don't know what they're doing. I mean, the orthopedic surgeons. So that started the interest, and I did a follow-up study on 250 athletes who have had anterior knee pain. And I saw that after years, these patients were still complaining, but they have, you can say, learned to live with their symptoms because no one could do anything for them.
So by anterior knee pain, you mean?
Anterior knee pain, that was actually the first study I did.
That's pain in the front of the knee, anterior knee pain?
That's pain around the kneecap or in the front of the knee. Yeah.
And is it particularly an issue of athletes, or is it just that athletes are more demanding patients?
No, this special clinic was a clinic that saw patients who were in a sporting club. That was how they could get there. If they were in a sport club, they could go there, and they knew if they went there, they would have the best possible evaluation at that time.
Okay. Thank you for that. So my other question, is it something to do with young people? Can you take us through this and explain, what it means in terms of the patient's problems when they perhaps start off with the problem?
If we talk about patellar instability or kneecap instability, it's mainly young people, starting in normally in around 10 to 11 years, and then through the adolescence, so up to 90. After that, it's very rarely that you will have a first-time patellar dislocation.
And what do you mean by dislocation?
Yeah, a dislocation is where the kneecap totally disengages from the groove, so it will go on the outer side, and yeah, naturally
so it comes out this way, jumps right out?
Yeah, it just jumps out.
Okay.
And this hurts a lot. Normally it hurts a lot.
So that seems like a pretty big event, but are there grades of instability?
Yeah, I mean, the first time patellar dislocation is always a big event. And then some of these patients have continuously recurrent patellar instability, and often, sometimes the patella go out so easily that they, in the end, they can't nearly feel any pain. It's just uncomfortable. And there's all kind of specters of this. Some will have recurrent patellar instability once a year, every second year, and some will have it nearly every month. So it's very different.
So does it usually start with a catastrophic event like that?
Yeah, normally start with a catastrophic event, and in most cases there's no contact. They're just doing a twisting activity, and suddenly the kneecap falls out. In the rare cases, it's playing soccer or something like that, and someone put his what can you say? You hit the patella so it jumps out, but that's
so
a
it's
rare
contact.
yeah, contact event.
But normally it's not like that.
Normally it's not like that. They're just doing some kind of twisting, dancing, soccer, jumping, hopping.
Okay, now you gave me this slide, or we developed it together, that it's a continuum.
Yes.
So is recurrent instability at the far end of the continuum, or is there worse than that? And what do you mean by the opposite end of this continuum?
So the lightest kind of patellar instability is where the patella just subluxes rarely. It means it doesn't go out. It just feels like it's going to get out, and the patient have a feeling on uncertainty. It's uncomfortable, and then the other end of the spectrum, it's permanently dislocated. It never comes back.
Gosh, okay, that must be awful. So you operate on these people. What is the most frequent procedure that you do to stabilize this?
Oh, it's definitely the NPFL reconstruction. That means
Oops, sorry.
It's a new ligament on the inner side of the knee, stabilizing the patella. It's like a check reins of the patella. So we just put in a stronger ligament and to keep the patella there.
So this is a picture of the knee straight with the tibia. Now, it's rather a bad picture, but it was quickly done. The patella there,
Yes.
the femur or the thigh bone above, and so that the ligament ruptures and then the patella moves to the outer side. And does that mean that it stays there, or just that it comes out of the groove very easily?
You mean when the patella goes out?
Once the ligament is ruptured.
Yeah, once the ligament rupture, the patella goes out, and sometimes the patient needs to go to the emergency department to have it put back. Another situation, someone else helps the patient getting it back, or the patient knows what to do, and what to do is to straighten the leg. When you straighten the leg, normally the patella jumps back.
Okay. And you mentioned at the beginning that your experience when you started was that many doctors didn't know what to do. Were you referring to diagnostically, or were you referring to procedures such as this?
At that time, people didn't know anything about the biomechanic, what was really happening. Everyone was trying to sort out one operation that could help all of these patients. And there was a lot of discussion which operation is the best. And at that time, there was no NPFL reconstruction because the NPFL ligament, it wasn't invented. No anatomical people has done any dissection to see this ligament. So at that time, there was no individualization of the surgery, meaning that all patients had the same surgery, and if it didn't work, they tried another operation. And today we know there is a lot of different factors for the patella going out, and you need to sort out what is the reason why the patella goes out, and then try to fix that problem.
Okay, and just so that we've got a record of it, the MPFL stands for medial, because it's on the inner side, patellofemoral ligament, so the ligament between patella and femur. But it is commonly just called the MPFL, isn't it? Like the ACL for the cruciate ligament.
Precisely.
People don't tend to say it in words. Now, I've got one more slide before we finish. Can you tell us what's going on here?
In this situation, the patella is, I would say, subluxed. It hasn't really gone all the way out, but it's on the way out of the groove. Yeah, that's what I see.
Okay, and this the groove doesn't seem to be in the middle anymore.
No, the groove is medialized, and the trochlear, it's dome-shaped.
But here, okay.
Yeah,
dome-shaped.
It doesn't look normal. It seems like there is trochlear dysplasia. This is the most frequent reason why the patella dislocate. That's undevelopment of the trochlear groove.
Okay, so that's trochlear, which means the groove, and dysplasia, which means abnormality of some abnormality with the formation of that region. Yes. Anatomically. Okay, thank you. So I'm going to see if anybody's got any questions. I have to just change applications here. Thank you. So we've got Tim Cooper from Australia who's joined us, and Johan Kleis who's joined us from Belgium. And Johan says he's seen patellar instability happening during a football match with a player, and he thinks he was a Danish player at the European soccer. So would this happen frequently during active events like that, or are these footballers so well conditioned and worked up that it's not very common?
Is it me you ask, Sheila?
Johan says that he saw this during a football match.
Yeah.
Would it be something common in a footballer, or would they have such strong legs and such have been examined so well that it's not likely to be in that kind of group of patients?
Normally, it never happens in soccer because people are in an age group where if it was supposed to go out, it would have gone out before they reach their professional career, before they reach 20. So I think the case Johan referred to was a case where there was a rupture of the patellar ligament.
Okay.
Yeah, so it was a little bit different situation. Yeah, very unhappy situation.
I'm sure. And do you recall that that incident?
Yeah, if this same incident as I think happened was, I can't remember, it was Andersen. I think his name was Henrik Andersen. And yeah, he had a ligament rupture.
A ligament, a cruciate ligament, or a ligament, the NPFL ligament?
No one of these. The patellar ligament, the ligament sitting on the tuberositas tibia, very, very strong ligament. It's very rarely that this ligament rupture, but yeah.
So that was the thing that we looked at earlier, which I'm going to see if I can bring up. So you're saying this ligament ruptured?
Yeah.
Okay, yes, that is very unusual. Perhaps he was on steroids or something, I don't know.
I don't know either.
And the NPFL is the ligament here, huh?
No, it's on the outer side. It's on the inner side.
Inner side, sorry, I'm going the wrong way.
Yeah.
Okay.
There.
And just one more question here. One moment. I think that my audience are probably seeing me jumping between my slides, which is not very good, but I can't help it. Tim is asking, can imbalance between vastus medialis and vastus lateralis or a weak VMO contribute? I'll just translate that for Johan. So those are three components of the quads mechanism. So he's saying, can imbalance between them contribute?
I know this discussion has been going on for years, and there's a lot of papers coming out on that, but I don't think there is any scientific proof for this. I know that the VMO, it often become insufficient when you have knee problems based on pain. And
so I missed the word there. It becomes inadequate.
Yeah, inadequate.
Yeah.
And naturally, the VMO is important for stabilizing the patella, but I think it's a secondary problem to the knee that you have an inadequate VMO. So yeah,
so all the many years of focusing on that muscle on the inner side of the quads, the VMO, is not as important as having an intact ligament deep to it, the NPFL ligament.
I mean, the VMO is definitely important, and I still believe that if you have a first-time patellar dislocation and there's no severe abnormality in your knee, then you can have a good knee doing VMO training in order to get it back to normal. But if you have severe abnormality, I mean, you can train and train and train, but you will never reach the stability you need, and then you need the surgery.
Okay, great. Thank you. So we'll stop there. That's fantastic. I'd like to thank Johan and Tim for coming into the webinar. and thank Lars. Lars, when we close the webinar, don't go away, don't hang up the phone, all right?
Okay.
So there's one last comment here. So Tim is saying it's that the VMO, I think he means, probably contributes more to a tracking issue than to actual instability. Would you say that?
Yeah, I mean, in patient with anterior knee pain, the VMO definitely has an important role, but in the instability situation, it's more secondary.
Okay. Okay, thank you very much, Johan, Tim, and Lars. I hope we'll have more of these in the future and be able to work our way through all the various issues to do with patellar instability, but this was just an introductory talk. Thank you. I'm going to stop the broadcast now.